Good afternoon, everyone. So, I would like to welcome you all to today's virtual CPD. My name is Sabina Beidu, and I'm a pharmacist and a medical representative with Servier. Now, I'll be your moderator for today's session, and today we'll be looking at how to manage your diabetic patients during fasting, with emphasis on the diabetes and Ramadan guidelines. We'll also be going through a real-life clinical case of a fasting diabetic patient. Now, to walk us through today's topic is our very own Dr. Ernest York, who is a consultant endocrinologist and a senior physician specialist at the Kolebu Teaching Hospital. Now, before I hand over to Dr. York, I would entreat all our participants to put all questions and comments or contributions in the chat box or in the comment section, and we would address all these at the end of the meeting. Also, do well to accompany all questions with a question mark so we can tell the difference between a question and then a contribution or a comment. And we are currently having a few issues with our internet for our facilitator. So if you could kindly bear with us, indulge us for another 5 minutes as we wait for Dr. Ernest York to join us. Thank you.
Sabana, can you hear me? Good afternoon.
Yeah, good afternoon, Prince.
This is Dr. York.
Oh, okay. Dr. York, hi. Good afternoon. Sorry.
Yeah, sure. Can you see me?
Yes, please. I can see you.
Okay. So, sorry for the slight hitches. What it is I'm not in Accra, and where I find myself, there's a lot of internet challenges. But I think now we are ready to go. We will make do. So bear with us as we progress. In case things don't go the way it ought to, but we trust that things will be done right and in a way that will ensure very successful discussion this afternoon. And thank you once again for inviting me. So Sabina, once you want me to start, CES will share my slides and I will take over from there.
Thank you very much, Dr. York. I think your slides have been uploaded, so you can please go ahead and start.
Okay, so thank you, Sabana, once again. What will happen is, because of the poor internet connectivity where I find myself, I will be switching off my video and just use the audio going forward so that my bandwidth will not be unduly affected, so that we can have a clear connection and discussion moving forward. So thank you once again. My presentations, as I've been given by Servier, will be in two parts. The first part will be looking at Ramadan fasting and what it entails in terms of the diabetes side of things, the risk involved as it relates to diabetes, and what are the things that we can do to reduce the risk associated and yet satisfy an important religious sacrament, especially for Muslims. But remember that it is not only Muslims who fast, but there's, this talk is really looking at the Ramadan fast, and that's where the focus of this discussion will be. So I really don't have relevant disclosures that pertains to this talk. So I'll move straight away to look at the outline for this presentation. Please, can you move? Yes, great. The outline for this presentation. So we're doing the introduction, which I've started already. We'll be doing effects of fasting on health in Ramadan, then how to prepare for the Ramadan fast, and how to manage diabetes in Ramadan to ensure that we minimize the potential adverse effects and also improve the outcomes, and briefly look at hypoglycemia in Ramadan, and it will conclude. So Ramadan, as we all know, is one of the big pillars in Islam. And for adult healthy Muslims, it is obligatory. And usually it is done in the Muslim calendar, the 9th month, called the Hijrah, and also called the holy month of fasting in Islam. But it really depends on sunset and sunrise. So depending on where you find yourself, the duration of the fast varies, usually between 12 to 19 hours. So whilst others may be fasting for 12, others may do as high as 19. What happens during this fast? Usually you are not allowed to take in food or drinks, you are not allowed to smoke and have sex, the almighty sex, you are not allowed to. And then generally one is, encouraged to avoid all forms of immorality and be seen to be pure, holy, and to be doing good. So about the meals, usually Muslims during Ramadan will eat twice. Some may eat once, but most people will do twice. And it is said that, a lot of the calories that the intake during Ramadan occur at put sunset meals. And sometimes I've had, friends laugh at colleague Muslims and said, what you're doing is not a fast. I mean, you fast the whole day, but in the evenings, you eat terribly a lot. And, with that may not qualify you as a fast. But that is what it is. So most people eat sunset a lot. And then studies, some studies have shown that, overall, the carbohydrate or the calorie intake drops. And, but it's contradictory with other studies, which have also shown increased caloric intake during this period. There's a lot more consumption of fried foods as well. So effect of fasting, I mean, of course, there's a religious aspect of it, but does it have any biological effect on metabolism? And indeed it does. Of course, you are fasting, so your blood glucose level will fall, and as a physiological response, the insulin levels will also decrease. And once your blood glucose levels fall, the counter regulatory hormones, the anti-insulin hormones, glucagon and growth hormone, would also increase in response to that state, hoping to generate more glucose for the body to use. Of course, once it's a fasting state, all the sympathetic activities are heightened, leading to increased cyclic AMP. And then there's also mobilization, a lot of fatty acids to produce ketone bodies to generate energy to meet the body's requirements. Now, let me quickly say that if you follow the guidelines and the recommendations, whilst it is a religious sacrament that every Muslim is encouraged to do, if you go by the book, most people would not be required to take fasting or will not be allowed to do fasting during Ramadan when they have diabetes. And we'll come to the reasons in a jiffy in subsequent slides. However, patients insist on fasting, because of the religious demands. Despite the recommendations by the health professional, many people don't agree and they go ahead and fast. But beyond this, the sacraments, what about health and disease? There's a lot that patients may derive from fasting. If you check the slides that is shown, the extreme right on the top, there's increased cognition, enhanced cognition, increase in enhanced neurogenesis, reduced inflammation. You have increased mobilization of glucose from the peripheries. There's reduced heart rate. There's decreased blood pressure. You also have increased mobilization of ketone bodies and a whole lot of benefit, including adipokines and adiponectin, which are in a balance that are, suits the body state and quite productive and advantageous to the body during fasting. So it is not just satisfying a religious sacrament, but it also has some positive health benefits when you do fast. Let me lead you to the recommendations by IDF on Ramadan. This is a summary of what patients are supposed to do, whether they're supposed to fast or not, depending on the risk category. So this slide is a bit busy, so I try to reduce it. So let's go to the next slide, and you find that it is, broken down. So the first category 1 is very high risk. Now, when you have very high risk, see the arrow, the box in red on the left bottom. The recommendation is that must not fast, and you must mark that word, must not fast, if you are very high risk category. And what constitutes very high risk category? Severe hypoglycemia within the last 3 months, unexplained DKA, hyperosmolar state, history of recurrent hypoglycemia, history of hypoglycemic unawareness, poor glucose control, acute illness, pregnancy, chronic dialysis or CKD stage 4 and 5, advanced macrovascular complications, old age with ill health. So a lot of our patients that you and I see will fall into this category. And so the recommendation says they cannot fast, yet a lot of them would rather would not come for medical consultation before Ramadan, or even if they consult you and you advise that they shouldn't, based on the risk profile that they have, they will still go ahead and fast. So let's see the second category. The second category is high risk. So the first one was very high risk, and the recommendation was must not fast. The high risk group, the recommendation is that should not fast. So whilst it is strongly saying don't not fast, the should is milder than the must. So, but let's see the ingredients. Type 2 diabetes with sustained glucose poor glycemic control, well-controlled type 1, well-controlled type 2 or mixed multi-dose insulin injections, pregnancy type 2, CKD stage 3, stable macrovascular complication, and it continues. The list, as you can see, is not too clear, but I'm sure if you just see it keenly, you'll be able to know the exact words that are being shown. So the first risk category is very high risk, should not fast, must not fast. The second category is high risk and should not fast. Let's look at the last, which talks about moderate to low risk. Moderate to low risk. And the moderate to low risk is well-controlled type 2 diabetes being treated, and then they may have one or more of the following, as you can see in the bullets below: lifestyle therapy, metformin, alcohols, TZDs, second generation SU, incretin mimetics, SGLT2, and basal insulin. And so these are the ones that ordinarily may be allowed to fast. Even that, listen to the recommendation. Decision to license not to fast is based on discretion of the medical opinion and the ability of the individual to tolerate fast. Okay, so whilst it gives you some leeway to be able to fast, yet it has to be in consultation with your medical practitioner to advise your patient that fast or do not fast. And even if you fast, these are the do's and don'ts. And once the patient is able to comply with those recommendations, they can safely go ahead. So, what advice, when they come, what advice would you give them or should you be giving them? The first one is consult your doctor. I mean, you're going to participate in a month length fasting for a chronic disease that is severe and can affect your health acutely and in a chronic manner. So once that is done, even before then, you should start practicing in the 8 month, because usually it's done in the 9 month of the Muslim calendar. So a month before, you should try and see whether you're able to tolerate the medications you are using vis-a-vis the fasting. And then with the approval of the physician, switch to other long-acting or twice daily medications. If you are on, say, multiple insulin dosages, it's recommended that you probably stick to just once or twice daily. And even if you're on oral medications that are taken twice, if they are long-acting ones that could be taken once a day, they are preferred. Of course, the impact of frequent intake of NSAIDs on renal function, especially when you're going to have a lot of dehydration during Ramadan. Those on frequent consumption of NSAIDs might be advised against that. And of course, the dehydration may lead to hypercoagulability, and anticonvulsants, antiepileptics, and anticoagulants are advised to be taken at night when dehydration is less and a lot more fluids have been taken. So let's look at a lot more detail of what we should be doing. So as I said before, the very top blue box says all patients should schedule a visit to the healthcare practitioner 6 to 8 weeks before a Ramadan. And then what is supposed to happen? Stratify the risk and develop an individualized management plan. Detailed history must be taken. Patient experience during previous Ramadan must be sought. So that is important, okay, to establish the history and build on that experiences that the patient may have. And then patient ability to self-manage diabetes, that is key. All right. And then there must be not just taking history and examine the patient, but you must educate the patient in a manner that at the end of the day, you're able to risk quantify the patient or risk stratify the patient to say that you can or cannot. And if you can, these are the things that you ought to do. Explore the role of SMBG because of the risk of increased hypo during that period. You ought to talk about it and teach the patient and encourage them to do more frequent SMBG, and then when to break the fast, the exercise that could be done, fluid and meal planning. They are all important medication adjustments that must be discussed. So once that is done, then you have to come to a decision. On the left, look at the brown box, advise not to fast. And these are done in the very high groups, as I said, in the high risk groups. But if they are allowed to fast in the low to moderate risk group, I've told you already, or said already, that the do's and don'ts must be emphasized so that the Ramadan fast period is as uneventful as much as possible. And then you increase your SMBG to ensure that you're able to track the glucose profile during that period. So now we're going to the last box at the bottom, which talks about all patients should break their fast. So let's remember this. Yes, you advise, but man proposes, God disposes. You advise, it may not go well. In case they experience hypoglycemia, that is a random of less than 3.9, they ought to break the fast, and then find some remedies. And then when your blood glucose levels are also going very high, above 16.7, you ought to break it because something might happen. If you are not careful, you may go into ketosis. And then symptoms of hypoglycemia, you may not have checked, but you feel that, this is what I'm experiencing is hypoglycemia. And then that will only occur when you have a priori educate the patient on recognizing hypos during this period And also when you're acutely ill, you are advised to break your fast. So these periods must be remembered, but it will become important when we are talking about medications and how to turn them around. So usually the evening, the number 5 is the sunset. After the sunset, then they break the fast, and it's called the iftar. And the dawn fast, at the breaking of the fast, is called the suhoor. Okay, so they would usually start the fasting at sunrise, that is suhoor, and then they eat and prepare for the day, and then during when the sun sets in the evening, they break the fasts, and the in between periods you can see for yourself. So it is suhoor and iftar. Suhoor is the dawn, and then the sunset is iftar. Okay, so it is not without risk. We have been able to risk stratify our patient, but we should also let them know that hypoglycemia is real. And indeed, because some of them binge eat, or maybe may not be taking their medication because they think that their sugars will go haywire, they can, also have a variability in their glucose profile. So apart from the hypos, they can also have hypers. Some may even go into ketosis, and dehydration is quite common, especially in the very hot areas in Africa, North Africa, and even the whole of Africa and the Middle East. It can be quite severe and daunting, and that may lead to thrombosis as well. So there are some studies I'll be showing in the next few slides. Hypoglycemic rates increases about 4.7 times in type 1s and about 7.5 times in types 2. And the data on hyperglycemia is a bit inconsistent. So the next slide will show one study that was published, the READ study, Ramadan Education and Awareness in Diabetes Program for Muslims with type 2. This was a multi-center study, and this is what it showed. Those who received diabetes education on the left saw a drop in hypoglycemic events compared to those who did not receive diabetes education before Ramadan or fasting. The rate increased by as much as 4-fold. So you can see that. So it is important to engage your clients or your patients before they fast, because one of the feared complications during fasting, hypoglycemia, tend to better or improve during that period if they receive diabetes education. And this is a confirmation of the study, the EPIDIA study, and also the READ. And you see 4.7% in type 1s and 7.5 in type 2. For those who received education, before Ramadan. Now, the reason we are tapping on the hypoglycemia state is not because, well, you can just feel dizzy, or feel sweaty and, feel funny. No, it goes beyond that. If you've had hypo before, you are on the edge. You are afraid to go into hypo again. And sometimes it may lead to overeating and paradoxically lead to hyperglycemia and poor glucose control. It may lead to cardiovascular complications, and I'll talk to you about weight gain and defensive eating. You may fall into coma. Unfortunately, some patients may die. You may have seizures, and indeed, many patients, not just Ramadan, but diabetes patients, have fallen into, have had hypoglycemia and had seizures and died in their sleep. So it can even lead to unexpected death. And imagine driving, and having severe hypoglycemia. It can be disastrous both for you as the driver and for anybody else who is with you in the car. Quality of life reduces. There's increased risk of dementia, and death may supervene. And I've told you about that already. So so we are towards the end of the first half of the presentation. We'll briefly want to look at medication. So we talked about the education and the preparation and everything else. What about medications to use? So we're looking at oral medications first. And metformin, the almighty metformin, overall dose should remain unchanged. And for those who take once daily dose, it is preferred that you take it at iftar. Iftar is the evening, because people tend to eat most during that time. But if you're on a BD dose, yes, you can still take it in a suhoor and iftar, morning and evening. If you are on TID dose, you can omit the afternoon dose, because really not eating metformin is after meals. So you ought to omit the afternoon dose, and you can combine the afternoon and the evening dose, to be taken in the evening. What about alcohols? It doesn't need any dose modification. TZDs doesn't need any dose modification. And then insulin secretagogues like the glanites. Again, because you are skipping lunch, you can omit that dose and combine it with the evening dose, where it is expected that you take most of you take the heaviest meal of the day during Ramadan. And again, GLP-1s really does not require titration once you are at a dose that is stable, or the HbA1c or the glucose control have been stable prior to Ramadan. You could stay with that dose. What about DPP-4s? Again, that really does not need dose adjustment. Now let's come to almighty sulfonylureas. So it is advised that switch to the second generation glycoside and glimepiride where possible. And please, let's stop using glibenclamide. I have stopped using glibenclamide. Any patient I see and is on glibenclamide, I stop it, especially when they are elderly, because it has a very high risk of hypoglycemia. So if you are on a once daily dose, it is advised that you take it at iftar. And if BD dose, you can maintain the BD, but somehow you could reduce the suhoor or the morning dose just a bit, so that you stay within safety, to cause some hypoglycemia. What about SGLT2 inhibitors? Again, that does not require dose modification, and the once daily dose should be taken with the evening meal. But remember that SGLT2 come with a lot of fluid loss and dehydration, and you are encouraged to take in a lot more fluid than you usually do, especially also when you are fasting during Ramadan. And for elderly patients with renal impairment, hypoglycemic individuals, or those on diuretics, SGLT2 during Ramadan fast is not encouraged at all. So what about insulin? Insulin is a bit tricky. So let's go through it gradually. Let's look at analog insulin. If you're on human insulin, it's best to switch to analog insulin because of the risk of reduced hypoglycemia with analog insulin. But in terms of specifics, those on once daily dosing, if you're using it in the night or in the evening, you can stick to that, but you ought to reduce the dose between 15 and 30%. If you're on a twice daily dosage, you need to flip it around. So the morning dose, usually, especially if it's premix, for instance, we tend to use a high dose in the morning compared to evening. But because this time you are eating more in the evening, you ought to flip the dose. So if it is 20/10 in the past, you are now advised to take 10/20. Okay, and then you may even then we can reduce the evening dose just slightly. So 20/10 becomes 10/20, but you can drop the 20 a bit to maybe 10, 15, or 16 or 18, and then titrate and adjust the dose accordingly. Those on prandial insulin, if it's 3 times, because you are not eating lunch, please skip the lunch dose and then maintain the dose, but you can reduce the evening dose by about 25 to 50%. I've already talked about the premix insulin. If it's once a day, take it in the evening. If it's twice, flip the dose, take the heavier dose in the evening and reduce it by between 25 and 50%. If it's a TID dose, omit the afternoon lunch and flip it as already discussed. So how do you adjust these insulins? And this suggestion here is made in such a way to make it easy to remember. So if your fasting or the random profile, depending on, it doesn't matter which insulin you are using, if it is less than 3.9, then you ought to reduce the insulin dose by 4. If your glucose levels is between 3.9 and 5, you ought to reduce the dose by 2. If it's between 5 and 7, you reduce it. No, there's no change. And between 7 and 11, you reduce it by 2. Increase it by 2, sorry. And if it is above 11, you increase it by 4. So it is 42024. So less than 3.9, reduced by 4. Less than 5, reduced by 2. Up to 7, no change. 7 to 11, increase by 2. After above 11.1, increase by 4. So just a simple guide to help you titrate the insulin during Ramadan. So this is a short recommendation from the South African Endocrine and Metabolic and Diabetes Society 2017 recommendation that they emphasize that sulfonylurea of choice should be glycoside modified release because of its proven efficacy to other sulfonylureas and consistently been associated with low risk of hypoglycemia and better cardiovascular and renal profile relative to other sulfonylureas. And then glibenclamide must not be used at the primary level. I've stopped using glibenclamide. And consider glycoside modified release as initial monotherapy when metformin is not tolerated or contraindicated. Okay. So just one study and then we'll finish this talk. Just a few slides. It's a real-world study amongst patients with type 2 diabetes that were treated with glycoside modified release during Ramadan. So the aim was to explore the real-world safety and effectiveness of glycoside modified release in patients with type 2 during Ramadan. So these were the methods that they used. It was a prospective international and multi-center observational study, and patients above 18 years were selected and had 2 visits before Ramadan, and about 6 to 8 weeks, and then they did the second visit 6 to 8 weeks after Ramadan. So patients received a diary, and they had to report changes that they saw, hypoglycemic events, any other adverse events, and then the primary endpoint was the proportion of patients reporting with more than one symptomatic hypoglycemic events. The secondary endpoints were changes in A1C, fasting plasma glucose, and body weights. This is quite a busy slide, but it's just summarizing what I just said. If you look at the V0 was the first visit, and they selected patients who were on glycoside, MR, either in combination or alone, and have received it for at least 90 days. And there was a rounding-in period, about 6 to 8 weeks, where they made sure that those treatments continued. And then during Ramadan, 4 weeks, and then they came back after that for certain parameters to be measured. But of course, the patient had a diary to record any adverse events that they saw. And these were the pattern of medication. So a huge chunk were just using glycoside alone, 41%. The next one is glycoside, metformin. There was DPP-4, SGLT2, GLP-1, ARCABOs, and TZ. So all the major groups were featured. So let's look at the results in summary. And clearly, in terms of confirmed hypoglycemia, event rate was just 1.6. It was 0.2 during Ramadan, before Ramadan, and it was 1.6 during Ramadan, and post-Ramadan, of course, it fell again. And then patients with at least one hypoglycemia was 2.3% compared to 0.2 before Ramadan. So clearly, glycoside MR used with other medications, either alone or in combination with other medications, did not increase the risk of hypoglycemia during Ramadan unduly, and indeed the rates were quite low. And this is again summarizing what I just saw. But in terms of, so look at the second bullet, there was a significant reduction in A1C, fasting plasma glucose, and body weight, okay, between the first visit and the second visit. So the authors concluded that patients with type 2 diabetes treated with glycoside MR alone or in combination during Ramadan have a low risk of hypoglycemia and maintain glycemic control and weight whilst fasting. And that's also busy, but it just gives it in a pictorial form. You can see the first row, changes in A1C, it was significant, compared to before Ramadan. The fasting plasma glucose again the changes were significant. And the last row at the bottom is the body weight, and the change was significant. We expect that using an XU, they may gain weight, but they didn't. They rather lost weight. Some may argue that, well, maybe because they are fasting. But again, but what it is clear that by the use of glycoside MR during Ramadan, it did not result in increased body weight. So we'll conclude, and remind ourselves that whilst we agree and we know that Ramadan is a holy sacrament for Muslims, it ought to be done in a safe manner, and there must be pre-fasting planning. And when they come, we need to assess them comprehensively through history taking, physical examination, laboratory tests, and then educate them, most importantly, because we demonstrated that studies have shown that those who undergo education before Ramadan experience less risk of hypoglycemia. And you need to select your medications which are safe, and not just safe, but in a way, combine them in a way that are safe to the patients. And that is why knowledge of those recommendations are important, and ensure increased fluid intake to improve hydration, and avoid physical activity in the afternoon, because of the risk of dehydration during that period. I think you don't want to unduly stress yourself, and ensure good calorie intake during the period. So thank you. This is the end of the first part of the presentation. So Sabine, I'm done. Thank you.
Thank you very much, Dr. York. If you have any questions on this first part, kindly note them in the chat box or in the comment section. Do well to accompany them with a question mark, and then we'll address them later on after the second part of our meeting. Dr. York, if you could proceed to the second part of your presentation.
Okay, so we should proceed. Okay, that's fine. That's fine. Okay, so I really don't have any relevant disclosures except what I've shown you on the slide. I'm not sure they are relevant to this talk. So next one. So just a quick reminder, to set the tone for the discussions going forward. So comprehensive diabetes care is everything that we ought to do. Both sides, both the patient, the caregiver, and the system that set up the care. Okay, so we always encourage screening and diagnosis, and we've come to know that lifestyle measures is the backbone of diabetes care, including patient education. because most of the time patients are going to live on their own 99% of the time. So without education and setting them, you set them up to fail. Right, then of course you need to give pharmacological agents to achieve control, and there must be good control to minimize the risk of complications. Despite what you do, some patients may have complications, they must be managed. One of the tools to achieving glucose control, apart from that, avoiding glucose excursions and hypoglycemia, is glucose monitoring. It's like a compass. If you don't know where you're going, you are, lost. So it's like it directs you whether you are doing good or not. We need money to finance care in diabetes, both for infrastructure to recruit staff and equipment, medications, glucose monitoring, and the like. Human and material resources we need, and then guidelines to help us make certain decisions like we are doing today. And everything else must be interpreted in the sociocultural context. What works in Accra may not work in Cape Coast, where I am now. What works here may not work in Tamale. So everything must be planned within the sociocultural context of the setting. And this is a rehash of what I just said in the previous slide, that all of these are important to plan Ramadan fast by consulting your physician or your doctor. It will come with education, history taking, and investigations, and then together you can decide to fast or not to fast. And then if you have to fast, how to do it safely using the right medications, the right attitude, the right skills, and we want to increase fluid intake during that period and improve our caloric intake. Next. So let's look at the first scenario. So we're looking at pre-Ramadan. So a 38-year-old kindergarten teacher, Muslim teacher actually, what she uses to finance her health-related costs is the NHIS that everyone uses or a lot of people use, and an out of pocket because it's not able to cover everything. Then diagnosed with type 2 years ago, has a family history of type 2 diabetes, and on metformin 500 milligrams once a day. Look at the blood glucose checking. She does that infrequently. And despite that, she recalls numbers of between 8.3 to 11.1. A1C is poor at 8.1. Now, the reason why she's still on 500 is that when they try to increase the medications, she gets bloated tummy and diarrhea. So they've not been able to increase the medication, and nothing else has been added also. She's overweight, BM26, no hypertension, no dyslipidemia, the renal function is fine, the eyes are also okay, no other medications. So look at the scenario that we just posted. So we go back to the risk category, and immediately we'll find that this patient is at high risk because he's type 2 with poor glycemic control. That is done. Okay, so that puts her at high risk. So the recommendation is that should not fast. But it's possible that within this should not fast, things can be changed to category 3. If she does or did the right things before Ramadan by doing medical consultation for a glucose to be optimized before Ramadan. So let's see the next slide. And this patient, additional information is that next slide, she did no pre-Ramadan reviews before. And then after week 2, next slide, please. After week 2, she was still on the same dose of metformin of 500 once a day. So it's a mistake. It shouldn't be twice. It's once a day OD, okay? And so after week 2, same dose, fasting is still bad. The postprandials are still bad. remember or see that the fastings are even worse now, and the postprandials are also worse because of the erratic nature of the eating during Ramadan. Yet everything else hasn't changed. Next. So what are the problems? So this patient did no pre-Ramadan review, and that is a big negative. Again, no lifestyle changes, including diet, because he didn't consult, he's not been educated. He didn't change anything in terms of what she eats, how she exercises, whether to drink increased fluid or not. She did none of those. And again, she was doing it by herself, so she didn't change any medications or increase or add. If she had consulted, that fact might have been different. Next. So what will be your next action considering patient characteristics and circumstance? So of course, we'll go through the first principles, patient education, because this patient has already started the fast anyway. And you saw her in the second, things are getting out of hand. Assess compliance. We know that the non-increment is largely due to side effects. Assess complications, advise on lifestyle, which is key to maintain good glycemic control. So what the physician did was just to continue on the metformin and add glycoside MR in the evening, and then advise for future pre-Ramadan medical review, which is key. So yes, you started, things are not getting on well. However, we will try and correct this as is now. But next time when you want to fast, please come for us to review your numbers and review everything else about you so that we can advise you appropriately. And let's see what happened. The numbers increased tremendously after these measures were taken. So that is a patient who had poor glucose control, did not consult before Ramadan, had issues with increasing dosages, and this was how the patient was managed. So let's look at case 2. So case 2 is also a Muslim administrative officer at the hospital working in Kolebu, 48 years, also finances healthcare through NHIS. But workplace, there's a 50% scheme where if you spend out of pocket on healthcare bills, they would refund 50% to you. And diagnosed 8 years with type 2, mother has and father has diabetes. She is on metformin 2 grams a day with glucosamine 2 milligrams. Again, SMBG infrequent. Fasting is between 8.2 and 11. A1C is also for 8.9. BMI 26, overweight. This time around, she is hypertensive, and renal function retinopathy are okay, but she has mild benefits. So that suggests some neuropathy and no other medications. So again, if you want to risk stratify this patient, she will fall straight into category 2. Poor sugar control, she has other risk factors, hypertension, and a strong family history. So ab initio, this patient, if she consults you, the answer will be should not fast. But that can be changed. So let's see what happens. So, but luckily this patient sought medical advice, unlike patient 1, 4 weeks before Ramadan. Despite the pronouncement by the doctor that because of your profile, you shouldn't fast, she insisted on fasting. So the physician really had no option than to help the patient go through the process as safe as possible. So she was educated, she was taking through lifestyle measures, diet and all. Because she's hypertensive, her BPs were controlled, she received antihypertensives, and then they give some medications to control her neuropathic symptoms. And then because of a risk profile, statins were introduced. In terms of what to use in addition to the metformin, they suggested the DPP-4, SGLT2, basal insulin SU. But she said she couldn't afford the SGLT2 and DPP-4. and she also did not want injections. So naturally, doctor had to stick to the SU that she was on already. But there was something that the doctor changed about the glibenclamide. So the doctor advised her to continue the metformin and then switched the glibenclamide to diamicron. And this is what the doctor did. He gave a lower dose of diamicron MR in the morning and then the higher dose in the evening, the suhr, the iftar. Okay. So having done that, after 2 weeks, unlike the other patients, the fastings have improved remarkably between 6 and 8. The postprandials who have fallen to 7.5 to 9. And there were no reported case of hypoglycemia, and Ramadan ended uneventful. So you compare a case of somebody who planned his Ramadan and the outcomes compared to somebody who didn't plan her Ramadan, and the effects on or the outcomes that each of them suffered or had. So proceed quickly to the last case, which is case 3. And this is also 48 Muslim accountant at Ghana Post. NHIS for healthcare financing, workplace scheme 80% and out of pocket. And diagnosed 4 years ago, family history, that mother is a diabetic. She was on, is a male, sorry, so he was on 2 grams of metformin a day, premix insulin 2014 morning and evening. So 20 in the morning, 40 in the evening, SMBG infrequent, and it's also poor, 8.2 to 11, A1C is also poor, and also overweight. She had additional risk factors, hypertensive, dyslipidemia, CKD, but had normal renal function, no retinopathy, but had benefit at night, and no other medications apart from the ones listed, the metformin and premix. Again, this patient is high risk. So poor sugar control, CKD stage 3, other complications and all. So CKD, she is stage category 2. So the advice again is should not fast. So let's see what was done to enable her to be able to fast. So again, this patient sought medical advice 4 weeks before Ramadan, and despite the pronouncement by the doctor that you cannot fast, again he also insisted, and the doctor had no option that to help the patient achieve their religious desires. Again, the same processes: patient education, lifestyle, BP control of neuropathic symptoms, and statins. Now, these were the medications that were suggested: DPP-4 inhibitors, SGLT2 inhibitors, sulfonylureas, and then to intensify the insulin therapy that she was already on. Remember that she was on premix insulin 70-30, morning dose of 20 and evening dose of 14. So the doctor's advice after the initial things was to continue the metformin 2 grams a day and to flip the premix insulin. She was on 20-14. Okay, so she took the 20 in the evening and then brought the 14 in the morning, but reduced the morning dose because hopefully the food quantity would have reduced. And then 2 weeks into the fast, the numbers remarkably improved. Fasting 6 to 7 postprandials, also quite nice. The patient suffered only 1 reported case of hypoglycemia, but largely Ramadan fast ended uneventful. So, I just want to show you the slides again on the insulin therapy. Okay, so the premix insulin, if it's 1, take it in the evening. If it is 2, take the morning dose in the evening and reduce the evening dose by up to 25 to 50% and take it in the morning. So this is exactly what the doctor did. So to conclude, this case, the cases I've shown you illustrated pre-Ramadan preparation and medical consultation are important. Indeed, they are key in ensuring that the outcomes of the fasting during the holy month is desirable. But we ought to be abreast ourselves as physicians to be able to take care of our patient well. So we need to know the medication types that are safer and in the combinations and in the posology in a way that will achieve one glucose control and will be safe in terms of hypoglycemia for our patients. So thank you so much for indulging me to this time. Thank you. Sabina, over to you.
Okay, thank you very much, Dr. York, for this insightful presentation, for taking us through the preparative stage that is prior to Ramadan, and then giving us case scenarios that you have encountered in your practice. If we have any questions so far, we will take them. If not, I would proceed with my short presentation as well, and then we can take all questions in the end.
So Sabina, I suggest that you do your presentation and then we can take all the questions in the end.
Okay, Dr. York, thank you very much. Okay. So, like I said in the beginning, I'm a pharmacist with Servier, and we'll just be going through a brief presentation on our branded glyclazide MR formulation on the market, which goes under the name of Dimicron 60 MR. Now, 60 because it comes as a tablet of 60 milligram, which is scored. And so if your patient requires a lower dose of 30, he or she can easily break for that. Now, the MR stands for modified release, and it is one of the characteristics of this formulation that makes it very safe for your type 2 diabetic patients, even during fasting period. So we realized that during Dr. York's presentation, the guidelines, the IDF-DAR guidelines, and even the South African guidelines recommend the second generation sulfonylurea, where they have glyclazide. And in our case, we have it as a modified release in Dimicron 60 MR. So briefly, as you can see on your screen, we've seen that fasting is a religious exercise which is considered or viewed very highly in a lot of religious individuals. We have it both for our Muslims and then in our Christians as well. It signifies a test of faith, but for your diabetic patients, it can be a physically stressful period because they stand the risk of so many major events. So there's a risk of daytime hypoglycemia, which countless studies have proven that increases about 7.5 times, and also the risk of severe nighttime hyperglycemia, since most of them tend to overindulge and try to make up for all the meals they have lost during the day. So for your diabetic patients, you have that risk of hypoglycemia heightened and also nighttime hyperglycemia heightened. And also there's a risk of dehydration and therefore ketoacidosis. Now, when it comes to our market, one of the risks that we are also faced with has to do with the quality of our drugs. And we realize that Africa has become the dumping site for substandard drugs. I'm sure there are so many clinicians, we've seen this in our practice, where we've made the right diagnosis, prescribed the right drug, patient is compliant, and yet he or she is not up to target in terms of glycemic control or even blood pressure. And it's all as a result of the substandard drugs that are dumped on our market. So we know that when it comes to our chronic conditions, they are always guided by guidelines. And for your diabetic patients, one of the prominent guidelines in managing your diabetic patients is the ADA, which is the American Diabetes Association. Now, definitely, when you look at the algorithm for managing your type 2 diabetic patients, all first-line therapy must include lifestyle modification and then also metformin. Now, as to whether the patient is at a risk of atherosclerotic cardiovascular disease or is at high risk of heart failure or CKD, then you have the treatment protocols outlined as you can see on your screen. But then if you have a diabetic patient, non-complicated or without atherosclerotic cardiovascular disease or without a high risk of heart failure or CKD, then the ADA guidelines actually advises or recommends that you focus more on achieving and maintaining glycemic goals or glycemic targets. And in that regard, they have grouped the oral antidiabetics or the oral antidiabetics according to their potency in terms of achieving and maintaining glycemic control. Now, what I want us to focus on here has to do with those with a high potency, where we have your second generation sulfonylurea, as mentioned earlier on, also your metformin, and then your thiazolidinediones. So you can see that the guidelines make reference to second generation sulfonylurea, and the basic reason for that is, apart from their high potency in achieving and maintaining glycemic control, they also offer your patients a lower risk of hypoglycemia. Now, back to our context of Ramadan, where Dr. York, in his presentation, highlighted one of the bigger studies that included a much larger sample size. Which was done in 2020. Now, this one is quite recent, done in about 30 fasting type 2 diabetic Muslim patients who were also on dimicron 60 MR. Now, you can see that in this study, the goal was two things: to assess glycemic control and also to record the rates of hypoglycemic events. The slide, please. Hello there. Please, can I have the slide?
So Sabina, I think whilst we are waiting for the slides to be uploaded, if any of the participants has comments, I think they can let us know that we can start discussing them, and then once the slides are reloaded, then we can go back.
Yes, Dr. York. So apologies for the interruption in my presentation. To our participants online, okay, the slides are back. Let me just get on quickly with it, and then we'll continue with the questions and answers. So as I was saying, This is a much recent study done in fasting type 2 diabetic patients who were on dimicron 60 MR for the 30-day period of the fast. And there were two things being assessed here: glycemic control and also hypoglycemic events. Now you can see that prior to Ramadan, the average HbA1c was about 7.9. Then after Ramadan, it was 7.3. Now HbA1c is usually a better indicator of glycemic control. You can see, irrespective of the Ramadan or even the medication they were on, the dimicron 60 MR was able to achieve and maintain adequate glycemic control during the fasting period. Now, the remarkable thing here has to do with the hypoglycemic rates, where you can see there was 0% rates recorded for severe hypoglycemia. Usually, severe hypoglycemia requires hospitalization, and 0 cases were recorded. However, when it comes to the symptomatic hypoglycemia, that was we had a rate of 6%. But if you break it down numerically, it's actually 2 patients out of the 30. Now, someone may think, oh, this is a small sample size, 1 center, so 2 patients out of 30. But referring you to the DAR Ramadan study that Dr. York elaborated on during his presentation, that study actually also real-world study, multi-center, involved 1,214 type 2 diabetic fasting patients who were on glycoside MR60, so dimicron 60 MR. And for the confirmed hypoglycemic cases, it was 19. So I believe you would agree with me that for a sulfonylurea, that is quite an appreciable value, given the circumstances surrounding the use of the medication. Okay. Now, we know that dimicron 60 MR is a sulfonylurea, but it isn't your regular sulfonylurea. And why do I say that? So we have this Al-Sifri study, which was also done in the same context of Ramadan fasting for 1 month in 1,066 type 2 diabetic patients. Now, generally, the goal of this study was to compare hypoglycemic incidence in fasting Muslim type 2 diabetic patients treated with a DPP-4 inhibitor and sulfonylureas. So they grouped sulfonylureas and compared hypoglycemic rates to the DPP-4 inhibitor at the end of the 30 days fasting period. Now you can see that, of course, as a class as a whole, the rates were really high for the sulfonylureas. But as you can see, when they did a sub-analysis, because they were all not on the same sulfonylurea, when they did a sub-analysis, only dimicron 60 MR could rub shoulders with a DPP-4, which is considered a much safer class, looking at the rate of hypoglycemia being almost comparable to that of a DPP-4. So it stands out of the class of the sulfonylureas because you can see it is 2 times less hypoglycemic incidence compared to glimepiride, and then 3 times less again compared to glibenclamide. No wonder Dr. York no longer uses glibenclamide in his study. So you can see here clearly that dimicron 60 MR can indeed rub shoulders with other classes of oral antidiabetics with a lower risk of hypoglycemia and equally stand out of its class of sulfonylureas. So what are the qualities of this drug that accounts for the lower risk of hypoglycemia? So first of all, we'll look at the quality of the drug. So we at Servier have all our active ingredients manufactured in France under strict good manufacturing practices. So you are guaranteed of that quality of drug for your patients. Now, another peculiarity or specificity with dimicron 60 MR has to do with how it binds to the beta cell receptors. Now, we know that for the class of sulfonylureas, they stimulate insulin secretion, but they do that differently. So with dimicron 60 MR, the binding to the beta cell receptors for the secretion of insulin is actually reversible. So the molecule is able to attach and detach with time, and for which reason insulin secretion is almost in a physiological manner, mimicking the physiological state or the physiological secretion of insulin, thus putting your patient at a lower risk of hypoglycemia. Now, another quality has to do with the galenic formulation of the drug. It is in modified release. As you can see on your screen, the active ingredient is actually interspersed in a hypromellose fiber, and for which reason it goes gradually into the bloodstream over 24 hours. So the galenic formulation also guarantees a lower risk of hypoglycemia and also sets it apart from the other sulfonylureas, just as the reversibility of the binding to the beta cells. Now, another quality that could be accounted for when it comes to the modified release is also the 24-hour glycemic profile, or the 24-hour glycemic control that you can achieve with just a single dose of dimicron 60 mR. As you can see in this study, we're just assessing the effect of a once daily dose modified release glycoside formulation over a 24-hour plasma glucose levels. And clearly, there isn't variation. Dimicron 60 mR is able to mimic the physiological secretion of insulin and thus give you that 24-hour glycemic control your patients needs with just a single take in the morning at breakfast. So, like I said, for us at Servier, we guarantee quality for all your patients. And how do we do that? So first of all, like I said, our active ingredients are all produced or manufactured in France under strict good manufacturing practices. When it comes to our distribution, we are always in line with certified distributors to bring our products into the country, definitely under very good storage conditions. And also our packaging respects the recommendation of the WHO according to our zone. So we all know that climatic conditions sometimes interfere with the stability of the active ingredients. So our packaging goes into preserving the stability of our active ingredients based on the zone definition by the WHO. So in your fasting type 2 diabetic patients with dimicron 60 mR, you really don't need any dose adjustment. The only thing to do here is to delay the time they take their drug. So usually dimicron outside the fasting period is taken once daily in the morning before breakfast or before the first meal of the day. However, during Ramadan or a prolonged fasting period where most of the eating happens in the evening, we recommend that it is taken at the time they break their fast. And you can actually go as far as the maximum dose of 120 milligram. You could see that even in one of the case scenarios that Dr. York shared, the patient was actually on 90 milligram. So increasing the dose doesn't increase the risk of hypoglycemia in any way. So there's no cause for alarm for your patient. Thank you very much. So please, if you have any questions, we will take them now. Questions pertaining to Dr. York's presentation, the first part on the generalities, the recommendations by the IDF in terms of the pre-Ramadan education and also assessment, and how to walk your patient through Ramadan as a healthcare professional. And also, if you have any questions on the second part, on the clinical scenarios that he also shared, and equally on my part as well. We'll take them now. Thank you. Okay, so we have a question from Dr. David Sapon. What about other denominations that embark on long week fasting?
Long week?
Long week fasting, yes. What about other denominations that embark on long week fasting? So I believe he's referring to, Christians. I think Lent has already started. So do we apply the same rules to them as well as we do for our Muslim brothers during Ramadan?
So if you use Lent as pertains to the Catholics and the other Orthodox churches, I think it's pretty much similar to what the Muslims do with Ramadan. The only thing is that I'm not sure the duration relates to the sunset and then the sunrise. But it's also a month long, and they would usually do morning to evening. Of course, it varies from denomination to denomination, where sometimes they will do half day and all that. But so that means that the risk differ. But if you are doing 12 morning to evening, then they're pretty much same principles would apply. Even if you are doing half a day, you still need to consult your doctor if you have diabetes for everything to be ironed out, because there are certainly risks associated, especially those on medications that may likely cause hypoglycemia. And again, you are going to fast. So how well is your sugar control? What medication are you on? What is your risk in the past? How do we assess it going forward? Fluid intake here and there, complications that you have. Do you have hypoglycemic unawareness? Is it going to be worse for you or put you at a greater risk during fasting? So whether it is Ramadan or Lent fasting or any other fasting, it is going to be prolonged, and I suggest humbly that you must consult your physician before doing so. Thank you.
Thank you, Dr. York. Um, I hope your question has been answered.
So, Savannah, have you received any more questions or contributions?
None at the moment, Dr. York.
Okay.
Let's give them a few more minutes. Okay, Dr. York, as we wait for participants to bring in their questions, I have one myself.
Okay.
I would like to find out, in your experience as an endocrinologist, would you advise the concomitant use of insulin and sulfonylurea, whether in the context of fasting or not?
This is a frequently asked question, and the answer is a no and a weak yes. On top of my head, I mean, I would say no, but it can be done. The reason is that once you start introducing insulin, then the pancreas is being whipped, enough, and the insulin reserves are quite low, and therefore, if you're using an SU to squeeze the pancreas a lot more, you're not going to get much. However, it could do it, but it exposes the patient to an increased risk of hypoglycemia, right? But remember that in a part of the world, the choices are limited. Okay, so you do metformin, you do TZDs, you sleep before they're out there, but you know that GLP-1s, these BP4s, SGLT2 are quite expensive and out of reach for majority of our patients. So SU really forms, apart from metformin, one of the most important medications you use. So leaving it all together becomes tricky. So some patients, they are metformin, they are on SU, not doing well, you introduce basal insulin. But my approach is that once I introduce insulin to somebody who already is on an SU, I start reducing the dose of the SU with the hope that eventually I'll stop. Okay, so for a short period they could be on, but eventually the main aim is to stop it, because it put them at a high risk of hypo. But remember that if you're on a basal insulin, which is analog, and you are on an SU like say diamicron MR, which has an associated low risk of hypo, though it won't be our first choice to say go ahead and add an SU to insulin or insulin to an SU. The risk is reduced, and therefore, your worries may go down a bit. So to summarize, the answer is a yes, and a bigger no, and but a smaller yes. So it can be used with caution and in the right hands. Over.
Okay, thank you very much for your response. So Dr. Usu Nancy says, thank you for the presentation. Any side effects of the drug dimicron to note? Okay, so I'll take this since it has to do with dimicron. Definitely, because dimicron belongs to the class of sulfonylureas, you can't eliminate the risk of hypoglycemia. So hypoglycemia is actually enumerated as one of the side effects of dimicron. However, like I have demonstrated earlier on, based on the reversibility of the binding to the beta cells, the modified release formulation, the risk is actually reduced as compared to the other sulfonylureas. So the risk is still there, but it is reduced compared to the other sulfonylureas. So there's hypoglycemia, but at a reduced risk. We also have the hypersensitivity reactions, which are not very common, but this may be found in patients with G6PD deficiency because of the sulfonamide group in the glycoside molecule. Such patients are predisposed to certain hypersensitivity reactions. So you need to know your G6PD status before you initiate a patient on dimicron 60 MR. And then there's also the few cases of GI disturbances of diarrhea, but that's not very common. I would say largely it would be the risk, the hypoglycemic risk, which is however reduced with dimicron 60 MR. Thank you. Okay, so from Dr. Benedict Famous Atanga, please, what's the cost of dimicron 60 MR for a month dose? Also, are there 30 milligram formulations? Okay, so dimicron 60 MR, depending on the dose, like I said earlier, it comes as a tablet of 60 milligram. So a pack of 30 tablets, 60 milligram daily, goes for 192 Ghana cedis. Now, since it is called, if your patient needs 30 milligram, this 192 cedis is actually for 2 months. The 30 milligram formulations have actually been withdrawn from the market. So the reason is because we realize that most of the time, the 60 milligram is the most prescribed and is what gives adequate glycemic control. And also, we still brought back the 30, but in scoring the 60. So if you see any pack of 30 milligram on the market, it's actually been brought in by parallel importation. It is not registered with the FDA, and would strongly recommend that you advise your patients to get the pack of 60 milligram 30 tablets and do half a tablet for 30 milligram once daily. Thank you. Okay. The same Dr. Benedict Famous Atanga. Thanks for the presentations. Kindly share the slides with us, especially for some of us who joined late or had network issues. Okay, so the course would remain on the CES website for a period of at least 3 weeks. So you can easily refer and then listen at your own convenience after this live session has ended. Thank you. Okay. Dr. Benes Beidou is asking, so Dr. York, I believe this is for you. Please, for a type 2 diabetic patient, what should we prioritize during fasting? Glycemic control or hypoglycemia?
So, thank you for the question. Remember that one of the pillars of diabetes management is glycemic control. Okay, but the objects of pre-Ramadan preparation and Ramadan practices, safe practices, is to ensure that you achieve a desirable glucose control as safely as possible. So both ends are important. You want to achieve good control because your sugars can even go too low and you may have issues with hypoglycemia as I indicated, or they may go too high and may lead to other issues. You can have ketosis and all. But one, you want to reduce this variability in a manner that is safe. So both are important. That's why it must be planned. So which medication can help you achieve your A1C, desired glucose monitoring values? How should we combine them? What practices and lifestyle should I change or adopt to help me achieve those targets in a safe manner? So both are important and they must form ingredients in the planning and execution during Ramadan. Because you see, Savannah, just hold on a second. You can give effective medication to control your A1C, and the patient will get hypo and die. That's not what you want. Okay, so you need to balance the two, and they are all important. Over.
Okay, thank you, Dr. York. So another question by Dr. Frita Dankwa. Why do guidelines prefer the new molecules as next line after metformin instead of the sulfonylureas?
What do the guidelines do? What?
Why do the guidelines prefer the new molecules as next line after metformin instead of the sulfonylureas?
I don't know which guideline, but the guideline that Savannah showed is not respect to what do you call fasting per se. It's generally for type 2 diabetes. And there has been a progression of the recommendation. So currently what we have is you have to risk classify your patients. Is it cardiovascular disease that predominates? Is it renal? Is it failure? Is it weight loss? Is it hypoglycemia that is your concern? Is it cost that is your prime consideration? So depending on which ones that is your prime consideration, then you will select the medications appropriately. But if you refer to the guidelines on Ramadan, really what it is it's telling you what you can use and what you cannot in a safe manner. Okay, but certainly we know that metformin will always be one of the ingredients to select. And also remember that you would have risk profiled your patient already before the Ramadan. So if it is cardiovascular disease that is your prime focus, they will be on a particular medicine before. If cost was your prime focus, you have positioned the patient in a certain way. Then comes the pre-Ramadan fasting. Okay, you want to fast. What are the endpoints? These medications that you are on, Can we continue them safely? Can we change one or two? Can we change the dose? Can we flip the timing? You see, so it's this is how you should approach it. So the already diabetics who are on treatment, how then do you select medication in a way that improves glucose control, outcomes, and reduce hypoglycemia? Thank you.
Thank you, Dr. Yok. Dr. Opon, what other benefits does dimicron give apart from hypo and glycemic control? Okay. So, of course, apart from achieving and maintaining glycemic control and the lower risk of hypoglycemia, dimicron also offers the extra benefits of cardiovascular and renal support. And this was actually seen in the ADVANCE trial, which is one of the biggest morbid mortality studies done in type 2 diabetic patients, where we had as much as a 65 risk reduction in end-stage renal disease in patients whose glucose were controlled intensively with dimicron 60 MR. So there's also that component of renal protection. And even to add on to that, dimicron 60 MR is actually one of the few molecules that can be used in renal disease or kidney disease. We usually recommend a limit EGFR of 30 mils per minute when it comes to dimicron 60 MR. And of course, with that, you start with a lower dose of 30 milligram once daily, monitor your patient closely, and then up titrate. So to answer this question, on top of the glycemic control, we also have evidence backing its advantage in renal protection as well as cardio protection, and also giving it the extra mile of it being used in renal impairment as long as EGFR is not less than 30 mils per minute. Thank you. Okay. Dr. James Edusei, could you kindly rehash the titration of glycoside MR upwards or otherwise? Factors to note. Okay, so the titration in terms of the dosing, usually 60 milligrams once daily is what we recommend as a start dose. However, if you are dealing with a very elderly patient or one with renal impairment, you want to start with a lower dose of 30 milligrams once daily and monitor your patient closely, and then you up titrate. So it depends. If it's a much elderly patient, you are doing 30 milligram, you can go to 60, do 90, and the maximum dose is actually 120 milligram. Now, the higher you go, most doctors are scared of hypoglycemia. But as I highlighted earlier, with dimicron 60 MR, based on the formulation, the MR formulation, you can give your patient 90 milligram or even 120 milligram as a single dose and still have no worry for hypoglycemic episodes. Thank you. Dr. Owusu Gideon, what makes dimicron MR different from other brands of glycoside? Okay, thank you for that question. So, first of all, I would start with the formulation being modified release. So we realized that glycoside was actually discovered by Servier, and it was a plain and immediate release formulation. And it did come at a dose of 40 or 80 milligram. Now, what's the downside to that formulation was that, first of all, because it's immediate release, the patient takes it, all the active ingredient goes into the bloodstream. So you need to take it multiple times to have that 24-hour glycemic control. Okay, and also the risk of hypo is actually quite elevated with the immediate release formulation. That is why we went ahead to innovate on that and make it a modified release, where the active ingredient goes slowly into the bloodstream over 24 hours. So with just a single dose of the modified release dimicron, your patient is looking at a 24-hour glycemic control and also a lower risk of hypoglycemia. Thank you. Dr. Osei Mensah Ebenezer, Dimicron MR, how much does it typically cost? Is it on NHIS and can it be given to DM hypertension clients? Okay, so Dimicron 60 MR, 30 tablets, that's a month's supply, is actually 192 Ghana cedis currently. And this is as a result of our current economic situation and the inflation rates and the depreciation of the cedi. So it's currently at 192 Ghana cedis. Unfortunately, it is not on NHIS yet. We are working on that. And it can be given to diabetic patients with hypertension. So Dr. Apau Akwesi Asante, are there any common drugs of or inhibit the effect of dimicron when taken together? Sorry, let me. Okay, I understand. So you want to know if there are any drugs that antagonize the effect of dimicron when taken concomitantly together. So, well, we have drugs that would increase the risk of hypoglycemia, like miconazole, because it would inhibit the metabolism of dimicron, and for which reason it will stay in the blood longer. So the risk of hypoglycemia is elevated, and for which reason it's contraindicated. We also have phenylbutazone, and then, of course, concomitant use with other sulfonylureas will increase the risk of hypoglycemia. We have your beta blockers, your fluconazole, and ACE inhibitors. Now, for drugs that would increase the risk of hyperglycemia because it would actually favorize the metabolism of dimicron, we have chlorpromazine, the glucocorticoids, salbutamol, terbutaline, and St. John's worts. So these are all drugs that would affect dimicron's metabolism one way or the other, either inhibiting it or um, enhancing the metabolism. Thank you.
Savannah, do you have any more? Because we've done 1 hour 40 minutes.
Yes, so I think the questions, I think there are no more questions. And I believe it's safe to say that your presentation did answer everything for our audience. That is why the questions may basically there weren't so many questions. And thank you very much, Dr. Yok, because this fasting and diabetes is a very sensitive issue. I know there are a lot of clinicians who came into this meeting thinking that, oh, your diabetic patient should be prohibited from fasting altogether. But then with you walking us through the pre-Ramadan assessment and the risk stratification, we all know that now there are some patients, diabetic patients, who can actually fast, of course, under review, pre-Ramadan review with their healthcare clinician. We've also seen that definitely the risk of hypoglycemia and hyperglycemia is elevated. And when it comes to sulfonylureas as a class, the second generation is recommended, and the South African guidelines actually highlight the modified release glycoside, which we have on our market as dimicron. When it comes to the dosing, the only difference here is that they take it at night, especially with the once daily dose. So they take it in the evening when they are about to break their fast. I believe this has been a very insightful session, and we've all learned a lot. And definitely there was so many talks about Ramadan, but it equally applies to other denominations, as was raised earlier with Lent. And then also, even outside these specific periods, there are individuals who embark on individual fasts. So it's equally the same thing. So thank you very much, Dr. York, for this insightful presentation, for giving us the three case scenarios in which glycoside modified release was also used, either as an add-on to metformin or switching from glibenclamide for your patients. And we hope that in our follow-up with our clinicians, any further questions we have would be properly addressed. So to our participants, please, to be able to earn your CPD points, kindly complete your pre and post test on the CES website so that the points will be credited to your account on the MDC portal. Dr. York, thank you so much for taking out your time to share with us with your experience. And we also thank our audience for also listening to us throughout the period. I wish everyone a wonderful evening. Thank you.